I mean, it sounds like you're struggling with it. How long? I mean,
I don't know. I just feel like I can't fight this feeling anymore. You know what I mean? It's like I've forgotten what I've started fighting for.
Are you just quoting REO Speedwagon?
No. We should get started, though, because we really should bring this ship into the shore. All right, so welcome to the Back to Basics Guardian Test Prep podcast. We are excited to be here today. This is a podcast where two brothers, myself and Jason, one's a paramedic firefighter RN, and one's a ER physician. We're going to make you guess which one, or you listen before you know. But anyway, we come together and we talk about medical topics that can sometimes be complicated. And we like to bring them back to basics as best we can. Simplify them for you so that you have the knowledge and the things that you need to get out in the field. And what I like about today's topic is that it's not very normal. It's not something that we see all the time, which we like to get into those. And then we dive into those topics, but then we're also going to dive into topics on other episodes where we talk about things that you see every day. So we kind of want to cover the whole gambit here of just, different medical topics that you may come in contact with. So if you like what you hear today, you're enjoying the podcast, make sure you check out our NREMT test prep program, guardiantestprep.com. We've got over 15 hours of great content for you. Jason and I, we like to have fun while we teach. We cover all the national standards so that you pass that exam. We also have question banks and workbooks and lots of things to help you study. So again, check that out at guardiantestprep.com. If you are listening to this podcast for the first time, make sure you subscribe on your favorite podcast streaming service, and like us on Facebook and Instagram as well. We'd like to follow you there. So Jason, you want to jump in and tell us what we're going to talk about today?
Yeah, so today's topic, we're talking about organophosphates and SLUDGEM. So organophosphate poisoning, the symptoms that we'd see from that, and then how we would go about and treat that. And actually the reason that I picked this is for you listeners out there, we run a Facebook group called NREMT Practice Questions. So if you are if you're studying for the National Registry or anything like that, and you want to just start seeing some good National Registry-based practice questions that come up,
it's NREMT daily practice questions. So if you search that group, you can jump on. And I will say, even if you're not studying for a National Registry exam, I mean, I haven't studied for my medical boards in 10 years. I guess it hasn't been 10 years quite yet, but every 10 years I got to retake my boards. I still like to do questions. I mean, questions, I think, even when you're in practice and you already passed these exams, can really help stimulate you to remember certain things that, like the examination stuff sometimes zeroes in on stuff that's kind of irrelevant, but you just have to know. But a lot of times it doesn't, right? A lot of times it's things that can remind you of, I forgot that that's the pathophysiology of asthma, or, I forgot about organophosphate, these kind of things, right? So, make sure you check that out too if you want some.
We'll put a link in the description for you so you can check it out.
Yeah, awesome.
But anyway, on this site that I kind of help run, one of the questions had to do with, I forget what poisoning it was, but I kind of threw SLUDGEM in there and atropine as the treatment as sort of like a distractor, because that's a common, and everyone jumped right on that and they were like, SLUDGEM, atropine. So this is like something that we hear about a lot, but it's also like we don't know it very well. And we also just assume that like all poisoning must be organophosphate. Like when we get into like what organophosphates are and how the mechanism of action works, just understand that there are like lots of ways that your body can be poisoned. Organophosphates, for some reason, are a very
it's like a high
yield. Yeah, it's a high yield thing on the exam, and it's a high yield thing in the programs, and it's probably because we have like quick treatments for it.
So, and that's what I was going to say. So it's another thing too, like organophosphate poisoning. It's like one of the only ones you remember from like when I was in medical school as well, or like when I did my emergency medicine residency. So again, for whatever reason, it's one that like stands out, but I think it's because we have antidotes and we know how those antidotes work really well. There's lots of different poisonings out there. Like I said, if you're in our program, you can take a look at our toxicology lectures. We talk about a lot of them, the ones that are going to show up on the exam, and the ones that the National Registry considers to be important for EMTs and paramedics to know. And organophosphates is just one of them. And there's tons, right? There's cardiac drugs. There's sympathomimetic medications. There's
anything,
drugs
too much of anything.
Yeah, too much of anything, right? But organophosphates, we actually have an antidote, and we don't have an antidote for a lot of different poisonings and things. We have treatments, but not an antidote. An antidote is going to be something that specifically reverses the effects of that poison, and we don't actually have that for a lot, but we do for organophosphates. The other reason that organophosphates are, I think, like I said, a popular topic when it comes to toxicology and poisoning is because we also see them in like terrorism and stuff like that. So obviously that's been kind of a hot topic over the last 10 or 20 years. So that's another reason that they come up a lot.
It's cheap to make if you wanted to weaponize it.
Right.
So it is an easy way to.
And that'll be our
blanket a
follow-up
community.
episode, is we'll
make some.
teach you how to weapon. No, just kidding.
Let's start from the beginning. As we approach any scene where we suspect some sort of poisoning, exposure, hazardous materials type situation, we do obviously have to have a lot of preparation done and slow things down a bit and make sure that we're concentrating on our own safety first, right? Because you can't become the victim. Don't cause a rescue of the rescuer, right?
Yeah, and especially with things like organophosphates, as soon as you, especially from a hazmat standpoint, as soon as you expose yourself and didn't take those initial precautions, well, now you're in the hot zone and you can't really come out without contaminating everybody. I was able to go down to FEMA in Anniston, Alabama a few years back, and we did some kind of like mass casualty training and stuff. And that was one of the things, is that they put you through these scenarios where you had to diagnose what it was. So, me and a couple, I was the physician, and a couple medics went into this simulated house and found a patient who had certain symptoms. And then as we did our evaluation and exam, we were like, oh, this is anthrax. And they're like, what are you guys going to do? Well, the answer is,
we've been exposed to anthrax.
Yeah, we've been exposed to anthrax now, right? So we had to the answer was basically
wait,
shut all the doors. Yeah, shut all the doors, call the hazmat team. Guess what? You're now technically a quote unquote patient victim because you've been exposed. So these are important things we need to take into consideration.
So with all, hazmat possibilities, pay attention to your dispatch information, right? If you've got people getting sick and you're getting information like it's farmland and there could be possible pesticides, or if you're hearing, when we get into the symptoms of this, if you're hearing that they have this sequence of symptoms, you're going to have a strong index of suspicion telling you, hey, this is maybe not organophosphate poison, but this is some sort of poisoning. This is some sort of exposure, right?
I think
when that happens,
I was gonna say one big clue I think is when you have multiple victims. When you have multiple people having symptoms, that should be a really big red flag of could there be some kind of exposure going on?
So when you have something like that, you're obviously not going to enter the scene until you can guarantee that it is safe for you to go in and provide care. So you are going to stage, and that might mean, watching the emergency play out until it's safe. You know what I mean? And that can be a tough thing to do. But just some general things that we do with hazmat calls, stage far away from the incident, uphill, upwind. When it comes to hazardous materials, if it's a solid material, a good rule of thumb is usually to be 75 feet away. If it's a liquid, 150, so double it. And then if it's a gas, 300 feet away. That's kind of just as a general rule of thumb of don't enter that area.
And that's an exam type of thing you might see, how far should you stage for different things.
And then your emergency response guidebook, your DOT guide and things like that is going to tell you specific hazardous materials. What's the evacuation zone? How far should ambulances stage? It even gets into what are the emergency treatments for, at least the general ones, like flushing the area, or maybe we need a Mark 1 kit, we need atropine, those sort of things. So it's going to kind of give you an idea of how to get the ball rolling with that. It is not your job to be like the incident commander on one of these calls. It's your job to make sure that you remain safe, that you stage uphill, upwind. If you can identify with binoculars or whatever, you can get the story about what's going on and you can pass that information on. That's the most important thing. But don't enter until you know that it is safe for you to enter. So if you were to be treating a patient with organophosphate poisoning, this is going to be out of the hot zone, right? We usually have a hot zone, a warm zone, a cold zone. A warm zone is where we would do decontamination. The hot zone is where the contamination would be. And then the cold zone would be where it's safe to operate. And you're going to be treating patients in the cold zone. You're not going to be in the thick of it doing that. That's not safe. That's going to, make you exposed. So
what's nice about that emergency response guide too, is that it'll tell you almost it'll tell you how long you can be in the hot zone for rescue. You know what I mean? If there's a certain time exposure, things like that. But again, that guide is really, really good. One, if you know how to use it. So if you've never used it before, make sure someone teaches you how to use it or review it yourself. But also you have to know that you need to grab it. So if you never suspect that this could be some kind of exposure and you never grab that book, well then it doesn't really do you any good. So knowing where those resources are And having a high index of suspicion on certain calls that you would think to grab something like that is important.
And it might be just as simple as communicating with dispatch, and just saying like, what do we have on this? What information do we have? And then, hey, which way is the wind blowing? You know what I mean? Is it safe for me to enter? Confirm those sort of things, right? So it's all going to depend on your system, but just make sure that you're having these considerations and you're protecting yourself first. So we just want to highlight that importance of scene safety and self-protection before we even render care, because this is a dangerous thing to be playing around with. So especially too, like you were mentioning, organophosphates specifically can very much affect community health if we let that, if we let that exposure spread, right? So this isn't a disease. It's not like someone with organophosphate poisoning shows up and gives it to somebody else, right? The environment would be kind of enriched with that, and that's the issue. So stay out of the environment, let those people come to you, and then treat them appropriately.
And we even run into this in the emergency department as well, where like we have to consider, like if someone comes in with symptoms and they've got that organic phosphate stuff on their clothes, and then I do my exam, and all of a sudden my nurse starts getting symptoms, and I start getting symptoms. Like this has happened in the past. Where like, so again, that it's not that the patient themselves like coughing on you and giving you but no, it's like they have the
contaminations off.
Yeah, they have the contaminant on them, and they can spread it to other people. And that's
which is why you guys have emergency procedures outside, like in the EMS bays. A lot of times you'll set up a whole decon situation. You'll rinse, you'll do all that stuff to try to decon those patients and then keep them kind of semi-quarantined while you treat.
Yeah.
That being said, when we get to treating them, and it's safe to do so, we need to understand what we're dealing with. So can you explain a little bit to me about how organophosphates work? And maybe even before we get into that, maybe let's talk a little bit about acetylcholine and acetylcholine esterase and kind of how those neurotransmitters work in our body.
Sure. So organophosphate, so the typically, especially in this day and age, where you're going to run into organophosphate poisoning is going to be like pesticides, fertilizers. So,
like you mentioned, terrorist attack, that sort of thing. That would be like sarin gas, VX nerve gas.
Right.
Those are designed. Those have organophosphate mechanisms that are designed to harm you.
Exactly.
But accidental stuff is going to be poisoning from pesticides. We use organophosphates to treat crops, to kill bugs.
Yeah. So someone's cleaning out their barn, or someone's like, working on their farm and that sort of thing, and they can get exposed to these types of things. So organophosphates, essentially what they do, and then we'll say what they do, and then we'll jump into how this all works. So organophosphates cause symptoms by essentially keeping around acetylcholine longer than it should be. So then, like you said, what does that even mean? So acetylcholine is a neurotransmitter. So a neurotransmitter is essentially a chemical that will travel from one nerve or one neuron to another neuron to relay a signal. So if you think about your neuron, you've got your cell body, which is like the head of the neuron, right? And if you don't remember what it looks like, stop the audio or stop the video and quickly Google the anatomy of a neuron so you know what I'm talking about. But the cell body is the part of the neuron that holds the nucleus, right? Then there's the axon, so that's the pathway that runs down, and then we get down to the axon terminal where we have dendrites, and these are these kind of little tentacle things that go out. So a nerve impulse, basically through the exchange of positive and negative ions, will run down that axon to send a electrical signal, if you will, from the cell body down the axon to the axon terminal and the dendrites. That then, the dendrites essentially release a neurotransmitter. So that electrical signal will stimulate the bottom part of the neuron, if you will, to release a neurotransmitter, which will then float between the dendrites of the one to the cell body of another neuron.
So you got tentacles on heads, tentacles on heads, and this huge chain, right? So the tentacles are releasing these
neurotransmitters,
this chemical, and this chemical's traveling across the tiny little space in between the tentacles and the head.
Synaptic cleft.
And then it's going to bind to that motor neuron, or whatever neuron we're talking about. It's going to bind to that head, and then that's going to trigger the ion, and that's going to continue the electrical signal. So a lot of people don't really get this. A lot of people, I think that like lightning's traveling through our body, and there's not like there's slow relatively chemicals happening, and then there's also fast electricity. But that electricity is generated by shifting of chemicals, activation.
Well, ions, yeah, exactly.
Yeah,
Positive and negative.
But the chemicals have to activate that ion, that action potential. So without that acetylcholine, you're not going to get the effect that you need,
Right.
and it's not going to continue the impulse.
So main neurotransmitters in the body. So acetylcholine actually was the first neurotransmitter ever to be discovered. We didn't really, before we even realized what neurotransmitters are, that was the first one. Other neurotransmitters though, so other chemicals that will travel between neurons to initiate action potentials in that electrical pathway. Dopamine, norepinephrine, GABA, GABA, that's another one. Glutamate, these. So you kind of probably remember some of these terms, right? So acetylcholine is one of these neurotransmitters, and acetylcholine you probably are familiar with because we've studied it a lot more than some of the other ones from a neurotransmitter standpoint. But what it does is that it, like I said, it enters that space between the dendrites and the next cell body, and then it binds to that cell body to start another thing. Well, when it's floating out there, it has to be broken up in order for it to go away, right? It can't sit there forever. We need to continue this ongoing.
Need to reset the cycle.
Yeah, we got to reset the cycle and that sort of thing. So there is a enzyme called acetylcholine esterase that will then come into that space and break down the acetylcholine actually into a choline and acetic acid, and then that gets reabsorbed. And like I said, we restart that pathway, right? So all these neurotransmitters have to be.
And it sounds like a mouthful, but just remember, ACE always means like a breakdown. It's something that's breaking down, right? It's an enzyme, so it's breaking something down. So like if you have alteplase, we talk about in, when we're using TPA, things like that, it breaks down clotting. You know what I mean? So we can kind of think of ACE always means you're breaking something down. So we have acetylcholine, or ACH.
Right.
Acetylcholine esterase is just the thing that breaks down
the thing that breaks it down.
It's pretty simple. It's big words, but pretty simple concept.
Exactly. So what organophosphates do is that they bind to acetylcholine esterase and prevent it from breaking down the acetylcholine. So the acetylcholine basically stays around a lot longer than it should, and it stimulates these pathways a lot longer than it should, and then we get pathology from that. We get symptoms that we don't want because it should be absorbed quickly. It's not, and now we've got these lingering.
We get too much of a good thing, if you will, right? Like we need acetylcholine in order for certain functions of the body to happen, right? We want that chemical to be released, but if we don't stop it, it will continue to just run rampant, and we have extreme symptoms. We have extreme versions of that activation.
Right, exactly. So again, we've got acetylcholine as a neurotransmitter. We have acetylcholine esterase, which breaks that down to start the pathway over, and we've got organophosphates that when we get exposed to those, they prevent the acetylcholine esterase from breaking down the acetylcholine. So we have too much acetylcholine. Yeah, right. We have too much acetylcholine in the system.
And we would call this a cholinergic effect. So anything that when acetylcholine acts on something, we typically refer to that as a cholinergic area. It's a so you can have cholinergic effects and you can have anticholinergic effects, right? So our treatment for this would be an anticholinergic medication.
Right.
So you might hear that phrasing being used, but just remember that like cholinergic is involving acetylcholine. It's just the name for an acetylcholine involved system or tissue.
Right. So a cholinergic symptom or a cholinergic effect would be the effect that acetylcholine has. And then anticholinergic would be you don't have enough acetylcholine, or you're not releasing.
Either acting against acetylcholine or it's competing with acetylcholine. We're working in the other
opposite
direction.
Effects, exactly.
And I think medics and EMTs, we get confused because we want to just be like fight or flight and rest and digest. Those are the chemicals and hormones we got to worry about. And it's like, no, there's a lot of other stuff going on in your body, right? So, but you can think of that in the same concept as a beta agonist versus a beta antagonist. But everything's not beta, guys. Like everything's not talking adrenaline. This is very different. This is acetylcholine. It does different things. And we'll talk a little bit about what acetylcholine, where it acts in the body, and then why you then see these symptoms when we have too much of it.
Yeah. Well, that's the thing too, is like, and that's what's hard, I think, sometimes in medicine, is that there's different terms that mean different things. So like the parasympathetic and sympathetic, those are nervous systems. Those are systems of nervous tissue and neurons and organs that function a certain way. And then we have neurotransmitters that work in both of those. Like, so both parasympathetic and sympathetic use acetylcholine and dopamine and serotonin. They all still use those things, maybe some more than the other. But again, we're defining systems, and then we're defining transmitters, and then we're defining symptomatology. We talk about like toxidromes, like certain syndromes that can occur with certain toxins. It can get really confusing. Yeah.
And we don't have to know. That's what's nice about being in the field, is you don't have to necessarily know every toxidrome, every poisoning potentially, but you do need to recognize symptoms that make these things obvious, and then know your protocol and how to follow those. Having this background understanding is just going to make you a better provider, because you're going to understand what your medication is doing and how it's acting against the pathology of what this chemical is doing, right? So let's talk a little bit about that. The cholinergic receptors, the areas that acetylcholine works on, are kind of many, right? It works in the brain. It works in motor neurons to move muscles. It works in the eyes in terms of generating tears. It works in other mucous membranes where it generates mucus production. So it does a lot of different things. It's not like one thing. It's not turning. So when we turn all of these systems on, and we have too much ACH or acetylcholine in the system, we get what we call SLUDGEM system.
So SLUDGEM, SLUDGEM, is the acronym essentially that we use for. It's one of them. There's other ones, like dumbbells is another one, but it's the acronym we use to basically symptomatology that clues us into this is a cholinergic response. Now, organophosphates are not the only cholinergic like poison out there. It's just the one that we talk about.
But the good news is treatment for cholinergic response of SLUDGEM is still going to be the same.
Yeah.
So
this is not just treatment for organophosphates. It's treatment for cholinergic poisonings or cholinergic
and that's the thing, is there are a lot of animal poisoning. Like we had our envenomation episode recently, but when we talked about how there can be like neurotransmitter interruptions and stuff like that, a lot of poisons, stings, bites, things like that work on. They basically inhibit acetylcholinesterase as well, and have a cholinergic effect where right. ACH is stuck in the system. And that's why you start to have you have muscle spasm and twitching and things like that.
Yeah, there's some snake venom that is essentially this. It's a anti-acetylcholinesterase, just like an organophosphate would be, and it produces cholinergic symptoms. So the acronym is SLUDGEM.
So S is salivation,
leaking from the mouth.
And this isn't just like, I have spit in my mouth. This is like
truly
obscene amounts of salivation. Yeah, like ready to really get in there and eat, like right before a rib dinner.
All right, well, that's
that kind
weird.
of salivation.
It's getting weird.
All right, lacrimation, which means crying,
leaking from the eyes.
So if they're just crying like a little girl and they're just drooling all over themselves. Urination,
leaking from the bladder,
peeing themselves. This is not don't let this happen to you guys. You're crying, you're spitty, you peed yourself. Guess what D is? Defecation. Yep. Now you crapped yourself too. You crapped your pants. Mm-hmm. You are wet everywhere.
Right.
And leaky. Gastrointestinal upset. Well, no kidding. You just diarrheaed yourself. so this is really referring to like the muscle spasm of the smooth muscle. So this is like cramping. They'll have very bad abdominal cramping. And then miosis, which is pinpoint pupils. And then sometimes the M, we say muscle twitching as well. So they can have like muscle spasm, pinpoint pupils. Now, they don't have to have all of these things to be being affected by a cholinergic response. Like they can have some of these things. But we can kind of recognize these symptoms as saying, okay, this is excess acetylcholine, and now I need to treat.
So another acronym I'll throw in there, because this is one we learned from in emergency medicine, is dumbbells. DUMBBELLS. And I'm just going to cover the first couple here. So D is same as like defecation, urination, miosis, like you said, pinpoint pupils. And then we have two B's. So it's bronchorrhea. So like basically like leaky bronchioles. So you've got like mucus, like they're coughing up like mucus type of thing. And then bradycardia, because acetylcholine also will slow your heart rate down. So the bradycardia is another one. So just a couple other ones I'm going to throw in there. So then you also, dumbbells, I think the E is, I have no idea what the E is.
We'll look it up later, I guess.
I don't know.
Next time.
L, lacrimation. S, salivation.
There's another L though, and bell.
Maybe there's only one in this acronym. I'm just saying.
So SLUDGEM's a good one.
Use SLUDGEM, but like I said, things like bronchoria, which is that like mucus production in the lungs, and then also like bradycardia can also be.
It affects a lot of systems. Like
Right.
acetylcholine is involved in a lot of different systems, and that's what we were talking about earlier. It's not just like turning it on, turning it off, fight or flight, rest and digest. Like that's not really what we're talking about. It's lots of stuff. It works on smooth muscle. It works on skeletal muscle. It works in the brain. Like you'll see altered mental status and stuff. Like especially with super excess amounts, you're gonna have like shutdown of your neurological system. You're gonna have a lot of issues.
Well, and the acetylcholine, you see why acetylcholine is one of the main neurotransmitters in the parasympathetic nervous system. But again, we're not talking about parasympathetic nervous system. We're talking about cholinergic. So there's this. Oh, that's where it gets confusing. There's this overlap between and this is why it's good to know what terminology you're using. Are we talking about a system, a nervous system? Are we talking about a group of symptoms? Are we talking about a certain effects that one neurotransmitter has? They're all a little bit different, but there's a lot of overlap.
So let's say we see SLUDGEM. We know what's going on. Acetylcholinesterase is not working, so we are stopping the stoppers. So there's too much acetylcholine. What do I want to give? An anticholinergic, something that's going to eliminate acetylcholine,
Right.
or compete with acetylcholine,
Right. So how do we
to prevent it from binding to transmitters? Because remember, these are chemicals that bind to transmitters to activate a certain effect in the body, right? So acetylcholine is binding to things that's making you crying, making you crap yourself, making you pee yourself,
Right.
making you spit all over, making you just tummy cramping hard, and also you're spasming like someone having a seizure. And we need to stop that. So what atropine does is it's an anticholinergic. It competitively binds to acetylcholine receptors and doesn't allow, and like blocks what that receptor does, right? So acetylcholine binds to these receptors that make you cry. We give a medication, atropine, that binds to those receptors and doesn't do anything so that acetylcholine can't bind. So we would call that a competitive antagonist.
Right. It's competing and it has the opposite effect. Now, what's not happening here is that we're not affecting the acetylcholinesterase or the organophosphate at all, right? Like the organophosphate is still binding to acetylcholinesterase, so it doesn't work. Well, we're kind of just ignoring that, and we're just trying to competitively bind the receptors so that acetylcholine cannot. So we reverse those symptoms by stopping acetylcholine's
dangerous
binding.
activity.
Yeah, inactivity, right.
So we do this for long enough that eventually the organophosphate will be flushed out of the system, and then now acetylcholinesterase is working okay. So like long term, you and I out in the field, the paramedics and the EMTs, we're going to be giving atropine. We might also be giving something called 2-PAM. It's a drug that comes along with atropine in what's called a Mark I kit. These are kits that are kind of given to us by the federal government specifically for, hey, there's a big sarin gas thing, or there's a big attack with organophosphates, or there's a fertilizer plant exploded, and now we've got this big issue. Right. So the Mark I kits are to protect ourselves and to protect others by giving atropine and something called 2-PAM. So what does 2-PAM do?
So 2-PAM is like, so 2-PAM, so the number 2 and then PAM.
It's pralidoxime.
Pralidoxime is the generic name, I guess, for 2-PAM. And what that does is now we use that medication to actually try to deal with the acetylcholinesterase problem. So what happens is the organophosphate binds to acetylcholinesterase, and acetylcholinesterase can't work now to break down acetylcholine. What pralidoxime or 2-PAM does is it binds to the other part of the acetylcholinesterase to knock off the organophosphate so that it can start working again.
It's just kind of free roaming in the system and can be eliminated.
So that's more of that's more of like an antidote. We would talk about antidotes. So atropine and 2-PAM would both be considered antidotes to organophosphate. But in my opinion, I feel like 2-PAM is the actual antidote, and atropine is what is treating the symptoms.
Yeah, atropine doesn't really fix the problem.
Right.
Like it doesn't fix the underlying cause.
Yeah,
It doesn't correct that, but 2-PAM does. And that's why we kind of take this two-pronged approach. Let's start competing with acetylcholine to kind of prevent its excess, and then let's also try to fix the problem with acetylcholinesterase.
What's nice about this too is that so we've had this question before, like how much? Well, and the answer is as much as you need. So literally you're going to titrate, you're going to give atropine and 2-PAM doses every X amount of time. It tells you how on the vials and stuff, but you're going to just keep doing that until they're no longer crying and no longer peeing themselves and no longer sweat. You know what I mean? Like, you're literally going to titrate to effect with these kinds of things.
And you'll have, like, your protocols will dictate, and a lot of these Mark 1 kits will kind of supersede your protocol, and it'll dictate how much you can give, because it's going to be how much you have. The reason we have the Mark 1 kits is typically an ambulance isn't carrying enough atropine on its own, because we use atropine for cardiac effects mostly. So we don't usually carry enough atropine to be able to handle something like an organophosphate issue. That's why you have these extra kits that are going to get shipped out to you, or a special place that you can grab them.
And even that might not be enough. This is something that's interesting when you talk about planning for mass casualty events or planning for these disasters and terrorist type of attacks, is that we have a shortage overall, like per ambulance for sure, per hospital, even emergency department, we probably don't have enough atropine to handle more than one or two people.
So like, here's the thing: here's the secret, and you heard it here first. Not trying to start a conspiracy theory or anything, but like, we for sure have enough for ourselves.
Well,
so that's what they do, is they try to make sure that we have enough for providers so that we can go in.
Protect the first responders. So those Mark 1 kits,
a lot of times you're probably going to be using it on yourself.
Right. So those Mark 1 kits are really more designed to protect you. Obviously, like I said, we're going to use, we're not going to like, nope, this is for me, you can't have it. And the patient's like, hey, please, I can't stop peeing myself. No, but I mean, like, it's not like we're going to use them, but we don't, like I said, if you showed up on scene and you had 20 people exposed to organophosphate poisoning, your Mark 1 kit's not enough for maybe even one of them. It depends on how big the exposure is and that sort of thing. So again, there has to be, and this kind of goes more back to hospital systems and working with the Department of Homeland Security to make sure that you could get atropine in. We talked about this when we talked about envenomations too. Like, some hospitals don't have anti-venom. You got to know where you're going to get these resources. We
saw it with COVID, with stockpiles of vents and stuff like that. Absolutely. We can't be prepared for every single disaster, but we do our best to try to have stockpiles here and there. So this is one thing and this is why it's a popular topic, and it's something that's on the test and stuff, is this is one thing that we've kind of prepared for federally.
Yeah.
So it's nice to know, hey, if there's a big sarin or VX nerve gas thing, or if there's a big fertilizer explosion, like, what's
our plan?
Yeah, there are stockpiles where you can draw from. So you will have disaster planning happening there. You're going to have huge,
well, in each region, so the U.S. is broken down into regions in terms of where we store these different
emergency
types.
Management.
Yeah, emergency management regions. So like, if you're region 2, region 3, there are hopefully your hospital and health system planners and disaster planners. They know where that is, and they know how to get access to it and how they would do that in a quick.
So it's mass casualty rules. Things are going to change. Things are going to supersede your protocol. But now, if you bump into a patient that is having these symptoms, and it's a single event sort of thing, and you see these SLUDGEM symptoms, that that's a cholinergic response, and your treatment for that is going to be atropine until they can get definitive treatment. If we're for sure that it's organophosphate, you're using a Mark 1 kit or something like that, then you're going to go ahead and use that 2-PAM as well. And that's going to kind of supersede any of the rules that you're dealing with at the time.
Exactly.
So I think that
I think that's hopefully that was helpful for you guys. Again, like, this is we're picking one very specific topic here. Again, there's lots more to be said about toxicology and toxidromes and cholinergic, anticholinergic, sympathomimetic. I mean, we could get into all this stuff. We do in our toxicology lectures as a part of our test prep program. So again, if you have a chance to check that out, make sure you do. But otherwise, like I said, we appreciate you guys taking a listen. We really want to hear from you. So if you have topics that you'd like to hear us cover, shoot us an email. So the new email is going to be podcast@guardiantestprep.com. All right. Send any of your questions, comments, concerns there. And like I said, we'd love to hear from you what you'd like to hear more about. So thank you guys so much for tuning in, and we will see you next week.
Stay sweet.
Hey guys, we hope you enjoyed the podcast. If you did, we'd love for you to check out the rest of our content at guardiantestprep.com. We specialize in preparing EMT, AEMT, and paramedic students for not only their school, but also the National Registry exam at the end. NREMT test prep with over 15 hours of videos, workbooks, question banks, and everything you need to pass. We'd love to have you get involved. Again, guardiantestprep.com. Check us out.